Okay, welcome. So if you've got questions, there's a few students here in our program. If you have questions, you can raise your hand and turn on your video or microphone and ask away. If you're new to this weekly Q&A, it's for existing students who have gone through our two-day program or are in our advanced training and have questions about the curriculum. You're more than welcome to listen in as a guest. Dr. David Buck, welcome. All right, so if you have any questions, type them in the Q&A chat bot. So this time is for you guys to ask your questions. So if no one submitted any, you can submit questions in advance, and we do record these sessions and upload them within 24, 48 hours to our YouTube channel. So let me just share that link with folks who may not be aware. Do you have any questions? Otherwise, Simon, do you have anything you want to talk about, perhaps?
These sessions are here for everyone in the group to uh, explore any areas within postural orthodontics that you're confused over or have questions on. They're not specifically for me to bring on any new topics, so it's not a lecture, it's not a teaching program. But it's an opportunity for me to answer any questions that you might have in regards to early intervention and specifically for postural orthodontics. If you guys are here, please bring up any topics that you wish. If no one does, then we'll close the session off earlier. So, if you've made the effort to join, just raise your hand, type in the questions. You don't have to come on live, just type questions. Anything that is confusing you, anything that you're unclear on, I'm here to offer my thoughts.
Welcome, Candice. Welcome, Dr. Dutton. Got some mentoring students. Oh, okay. Got a question from David Buck.
All right, so I'm going to share the screen.
I'll copy that across so everyone can see the question. Thank you, David. First question of the day from David Buck. I'll read that out. I'll clean up the format, but
Okay,
you could start.
so question. Hi, how long are the retainers worn after bioblock active expansion? So retention is always something that we have to consider. Retention can be in the form of appliances, such as retainers, or even the existing expansion appliance. If it's in the lower arch, very often you may not change it to a slimmer profile, unlike the upper, which requires a slimmer profile, so no screw in the palate to increase tongue space. We are trying to prevent relapse. So the arch development that we have created is to counter the lack of strong posture and tongue support, creating gentle pressure and a broader arch form and a broader and a better AP and vertical relationship. So if all we do is use an appliance to create that change, then that change has to be sustained indefinitely, because all things being equal, if you remove the expansion force, then it will collapse back to its original position, or to a degree of the original position, depending on how much ossification there is in the bony structure. Now, if we have incorporated the second component of postural orthodontics, which is retraining the posture, then you have a much greater chance of self-correction or self-sustainability. So if the tongue remains on the palate and the teeth are lightly in contact and the posture is strong, then theoretically, once you've expanded, you don't need to retain. Very often, however, the reality is the families don't incorporate as much importance in the retraining, and often the clinicians don't focus as much attention in the retraining. And so you're going to have to hold that space for as long as you need to hold the space. So the answer is it depends on how strong the posture is. And in addition, it also depends on the dental age of the child. If you finish in a stable period where there's no changeover of teeth, then it's very different to if you finish in a final transition period. So if you finish at, say, 11 and the primary molars are starting to exfoliate, you basically hold it until the retention clasps no longer are retentive because the second primary molars have been lost. And so that transition phase can sometimes indicate the finish of the phase one, because you need to have movement for leeway space closure and for the transition. So it can be held for a very long time if you start very early. It can be held for a very short time if you start late. It can be a requirement for indefinite treatment. So you might have to move on to a phase two if the posture hasn't been corrected, because the arch will collapse, the teeth will move. So it will vary from child to child, family to family, age, biological age to biological age. Next question. For a 9-year-old patient, is it better to wait for all sixes to be erupted? The upper left six of my patient not fully erupted, even though she's already 9. Thanks. So 9 is an age where usually the 6-year-old molars are 3 years into the equation. So if we are 9 years of age chronologically and the sixes are not yet fully erupted, then it could be a very slow changeover period, or it could be an issue, right? Something that requires attention. So it's important to assess, are we just generally delayed in our growth and development, or is there a pathological issue that is stopping the 6-year-old molar from coming through? As far as when to begin active treatment, we normally, when we are in mixed dentition, I don't start treatment until the lower sixes are in the occlusal plane or roughly in the occlusal plane. Usually I'm not as concerned about the eruption of the upper sixes, but general rule of thumb is we delay treatment in early mixed dentition until the sixes are in occlusion. and that's just the more stable period of time to operate the process. Now, we have to consider if one tooth is slow, but everything else is on track, a 9-year-old will be within 12 months moving into late mixed dentition changeover, and that precludes starting treatment because we're again in an unstable situation where primary molars are changing over. So it's very important to have an understanding of whether it's an overall delay of growth or whether it's one tooth that's out of the timeline, and figure out why that one tooth is out of the timeline. All right, next question. What techniques have you found to help parents understand and commit to being compliant with GOPEX? What sequence of exercises do you recommend to start with? So, motivation to do exercises is driven purely by understanding of the significance of the goals. We have to be very open about the significance of posture. We have to have everyone understand the etiology of the malocclusion. If we don't differentiate the factors of environment with genetics, then the default fallback understanding position is always this is a genetic issue. If it's a genetic issue in the mind of the parents, nothing that they do with their child will make a difference. And they will rely solely on you as the clinician with your gadgets. If they don't believe it's environmentally influenceable, then the exercises mean nothing to them. They will have no reason to be motivated because they don't understand or believe that anything that their child does or that they do to help their child will make any difference, and that the mechanics of the gadget, the appliance, the braces, the plates, are the primary change apparatus. And so they'll believe that so long as they wear the plate and they turn the screw, then things will change, and they don't understand why they have to put in the effort. So it's up to the clinician to highlight the prime role that posture has, and then to highlight the adverse posture and function that their child has, and then make it important that they are focusing on that aspect. Historically, what have I done? If I don't find commitment to doing the exercises, then I will initially threaten to stop the appliance activations, and then I will threaten to cease treatment altogether. So they'll come in, they'll wear the plates. I won't start any exercises until they've accustomed to it. Then I will teach exercises, and generally the sequence will be chewing exercises followed by counting, or counting followed by chewing. And then once the counting is under control, the reading out loud. And that's basically the bulk of the GOPEX exercises. So how do I know if they're doing it? I just ask, are you doing the exercise? All right, they're usually honest enough to say yes or no. I will ask the child to demonstrate the counting ability. Depending on how confident they are, it'll be obvious whether they're practicing or not. And then I'll confront them if I believe that they're not practicing them. I'll say, these are very important. If you don't do them, the treatment outcomes that I promise won't be achieved and you won't get what you paid for. And I won't put us through this in order to get a nil result. And then the following session, if you believe that they're not doing the exercises, you'll say, okay, we'll stop turning the plate. And they'll say, oh, are we done? He says, no, we're not done. He says, well, what will stop turning the plate do? I said, it will stop the active treatment and we are not going to get the goals. And they'll say, well, if we don't turn the plate, how will we get better? The answer will be, you won't get any better. But I'm not going to allow you to activate the plates until you commit to doing the exercises and fulfill those requirements. And then the next time you ask them, are we ready to reactivate with you having done the exercises? If they say, oh, they don't show that they've done it, you say, okay, if you haven't commenced and fulfilled the requirements for the exercises, next visit we will cease all treatment and we won't be able to treat you from here on. So that's basically what it comes down to, a combination of you educating and motivating them, and then you setting the rules that it's both or nothing. Next question. Thank you for your comment on whether the expander produced parallel opening the palatal suture and thus a better increasing nasal. Can you comment on whether the expansion will produce parallel opening of the palatal suture and better increase nasal airflow? Rapid palatal expansion type treatment tends to open suture in a V shape, not affecting the posterior nasal cavity. Rapid palatal expansion is aimed at splitting the suture. And depending on where the applied screw is set and depending on whether it's anchored to teeth or whether it's anchored to the bone, will determine how much it creates a symmetrical split or not. When we are using semi-rapid expansion in removable appliances like the ones that we use, we are not splitting the suture. And we are making significant changes to the shape of the palatal vault, but not with the goal of splitting the suture. Whether that helps with improving nasal airflow, I've not done anything to test it. I've not done anything to study it. I found, as a general rule, if we have nasal congestion and we are suffering from some form of obstruction, either from snot because of rhinitis or enlarged turbinates or deviated septum, then it doesn't matter what we do. We're not really going to overcome a severe issue. Generally, ENT intervention is going to be needed. If we have reasonable airflow through the nose to begin with, then with training using the GoPEX exercises in combination with the expander, then the children find it much easier. So whether that's because of the retraining or whether it's because of the expansion, I can't separate differences. So I couldn't answer that. All I know is we get better orthodontic outcomes. And if we retrain the children with the exercise program, they have better nasal breathing habits. But because I'm always working in conjunction with ENT, the ENT helps us with clearing the passageway. Uh, but our biggest hurdle, irrespective of the expansion rate or technique, is always whether the nose itself has adequate flow or not. Next question. If a patient has very poor body posture and breathing, should we refer to a physiotherapist? So very poor body posture is something that should always be addressed. Whether you make a decision to refer or not is something that you have to decide on. Certainly, I don't think there's any physical downside of referring patients to get therapy to improve their body posture. Whether that's requirement or necessary is hard to say, but certainly it's something that we highlight to parents as improvement in body posture, improvement in oral posture has only upsides for the child. And if they can't self-manage this, then there may be reason to get professional help. So you can basically label it in those words and say that's a decision that you can only make yourself as a parent. You've got to juggle. Everything is a juggle between how much energy and effort are they going to put in. Parents will, make an effort to correct their child's posture just through observation and verbal recommendations, verbal reminders. But you'll tend to find that we live in a world today that with cell phones and iPads and lack of need for young children to be physically strong, that body posture is awful. And unfortunately, no amount of physiotherapy is going to outweigh the negative impact of smartphone technology and the body posture that seems to follow with the habitual use of these devices. So unfortunately, it's a lifestyle issue. Getting children to climb trees and to play sports is going to have a much greater impact on their body posture than any amount of therapy to counteract a lifestyle that isn't favorable to good growth and development. Question, what facial indicators do you see with positive changes in GOPEX? Less chubby cheeks, definition of angle of the mandible. So strong posture defines muscles and improves the tone, and strong posture favors forward growth. Good swallow function and habits create quietness in the facial muscles and improves the tone of the tongue and associated elevator muscles. So when the posture is strong and the function is strong, then you're going to have a deflation of the buccinators, so the cheeks will look less chubby, and you'll get a squaring off of the mandibular plane, and a greater increase in the forward growth. So you'll get better definition of the jawline. The face will take on a stronger profile, and you'll have a lower angle of growth compared to a higher angle of growth in poor posture, etc. So we know if we accept that a closed mouth resting posture optimizes growth and development, that optimum growth and development has a specific facial form where you have roughly a class 1 relationship with room for all the teeth in the back, the chin and the lips line up in the same perpendicular plane. The lip to nose angle is at a right angle, and the entire facial structure is well ahead of the forehead. So you'll get that superhero square jawline look. And then if you have poor posture, you'll develop alternative facial growth and development. So you get, the long face or the chubby cheek or the witch's chin, compressed dental alveolar, hook nose look. So basically, you're gonna look like a superhero, a victim, or a villain, depending on the growth and development, which of course depends on the posture. Next question, do you test them on the exercises, like recording them each visit? It takes time, but maybe this holds them more accountable. So it's a matter of you just deciding whether you want them to fill out a workbook or whether you want them to record on video. That they're the metrics that you can utilize. You can, if you can read body language, you can ask them, are they doing it? You can ask them to demonstrate their knowledge of the exercises. You can ask them to recite what the actual exercises are. So, you can, of course, have a very rigid accounting records, or you can spot test them. And so I've given you guys the tools for all mechanisms. I've given you workbooks that they can initial and return to you for a validation that they have been doing the process. You can have them send you video recordings of each of the sessions. You can spot test them. So it's up to you to decide what you would like to do. Next question. I don't work with the myofunctional therapist, so I'm not confident in knowing when they're done with GoFX. How do you know for sure? So we're not specifically interested in correcting dysfunction. We are basically looking at general reflex control. So we want to know, are they resting with their mouth open or closed? We want to know, is their swallow a physiologic swallow? And in speech, are they speaking with good adult control in punctuation? So how do we know? This adult physiologic swallow is very specific, with no facial activity, with teeth together and tongue squeezing to the palate, creating a vacuum seal. So at the end, you would just do the exercise, right? The GoFX exercise is effectively a water sipping exercise. So you watch their face. Does their face move when they swallow? Are they swallowing with their teeth apart or closed? At the end of the swallow, when they open, have they created tongue to palate suction? So they're not difficult metrics to assess. So if you understand what the exercises are, then you will know how to test to see whether they are doing it correctly. If you don't understand what the exercises are, then you will have no confidence to determine if they're doing it correctly, which means the fundamental retention methodology in this process will be lacking. So you don't need to be trained as a myofunctional therapist. You just need to train as a postural orthodontist or in postural orthodontics so that you are able to teach and evaluate the GoFX exercises. So study the exercises as I have shown you, both in the written documentation and the videos during my lectures, and you will be able to understand this very simple process and to mark the success or failure of this very simple process. Next question is, what is your opinion on mewing? So mewing is GoFX, isn't it? So Mike and I developed mewing based on my GoPEX and GoFX exercises. Right? So I developed GoPEX. He developed some aspects of GoFX, and I combined them together, and he combined them together, and that's basically all it is, isn't it? It's chewing like you mean it, eating with your mouth shut, swallowing with an adult physiologic swallow. So we're not trying to reinvent the universe. We are reminding everyone of what ideal action in function and in posture we should hold in order to optimize growth and development and to sustain a good skeletal and muscular relationship. All right. Now, where things are misused is when you believe that you can use things like exercises to alter growth in a non-growing adult. Right? If we understand that physiological and biological change is possible throughout your life, but it is of most significance in your childhood and has less capacity in your adulthood, then you will have a good understanding of how to utilize something like OPEX and something like mewing. If you half listen, half learn, and take on only what you want in your fantasy world, then you will, like all things, misuse and abuse and misappropriate something important and change it to be something that it's not. For a 7-year-old with hyperdivergence, could we still treat with stage 1? So in early growth and development, we have a much better chance of doing simple things to make big changes. So we have to stop thinking about what can we use in appliances, and we have to start thinking about what's the problem and are we able to address the problem. So what's the purpose of the stage 1 appliance? And the answer is it's to improve transverse dimension and to alter the position of the permanent teeth. Yeah, so you can make the upper wider, you can make the lower arch wider, and you can alter the alignment and position of the permanent incisors and the 6-year-old molars. Right? So that's the purpose and function of a stage 1 appliance. Now, a hyperdivergent patient has many unfavorable characteristics. What are these? Well, they can be very narrow. They can have increased facial form in the vertical dimension. They can have significant crowding of the teeth. They can have backwards rotation in their growth. They can have airway obstructions. Right? So they're typical characteristics of hyperdiversion. 7-year-old. What will a stage 1 appliance treat? Well, it'll make a narrow arch wider in the both upper and lower, and it will help reposition incisors, and it can be used to control eruption of the sixes. So how does that address the other issues? And the answer is, well, doesn't help them close their mouth, which is the primary driver of the hyperdivergence. It doesn't really unblock their obstructions, doesn't change their habits, it doesn't create the AP dimension that you need, doesn't change the backwards rotation. So the question is, what are you going to combine the stage 1 appliance with to address all the other factors? The answer is, well, if you address their posture, or if you unplug their obstructions, if you control the over eruption of the 6-year-old molars, then you might be able to chip away at the disturbances of that hyperdivergent growth. Are you going to be more successful at 7 compared to at 12? Sure, because you've had 7 years of divergent growth versus 12 years of divergent growth. So your answer is, if you have not developed an enormous divergence, and if you understand the root cause of that divergence, then you have a much better chance of gaining the changes that you want at an earlier age compared to a later age. Next question. 6-year-old in a Bible for 10 months, but the mandible is still retracted. Did face pulling for a month in the beginning. Posture is still no good. And I do to help the mandible come forward. So the mandible is retracted, so you have to figure out why is the mandible set back. The primary cause will always be open mouth resting posture. If you have an appliance, which is a bio block, which is an expansion bio block, like a stage 1 appliance, then you will, through the mechanics of the appliance, improve the width in the transverse, and you may be able to control the positions of the permanent dentition, but you will do nothing to improve the vertical and nothing to improve AP of the mandible, because what controls AP and what controls vertical is posture. If you have an open mouth posture, your mandible will be set back and its growth will have a backwards rotation. If you don't improve the posture and only use a bi-block expander, then the only thing you will improve is a transverse dimension and a little bit of control of the permanent dentition. So how can the mandible be expected to change its direction of growth if the posture is unaltered? The mandibular growth pattern is determined primarily by its resting posture. If the resting posture is unchanged, then why would we expect there to be any change in the mandible relationship in AP or in vertical? All right, we've got time for one more question, and then we're going to wrap up.
All right. Well, you guys might be thinking about the last question. Simon, I'm going to share my screen. Can you just stop sharing for a second?
Yep, so I'll call it a day on my end.
Sure. All right. Thank you. Thank you. Now, next week is Thanksgiving, so we're going to take a break. So we'll resume the week after. All right. All right. Thanks, Simon. I'm just going to quickly share for those of you who weren't aware, we have a special, kind of like a last minute special that just so happens is ending today. For those of you who haven't joined our 2-day program, we held it about a week ago. And we have the pre-sale offer. The recording should be available tomorrow or Friday, no later than this week. But if you want to get the recordings, just 147 bucks. I think it's one of the lowest we've ever offered it. And it includes the recordings from our Hilton event. We held a 2-day event at the Hilton in New Jersey. People paid $2,000 to $3,000 for that event. So you get the entire set of recordings from that event, as well as the November live stream 2-day event. Similar content, but we had a different set of guest speakers. So 2 to 3 hours is slightly different. The whole 14 hours. There's additional 6 hours of bonus Q&A sessions we recorded as well. Anyway, so I thought I'd just share that with you guys, whoever's a guest here tonight, not an existing student, or if you're a past student and want to get a refresher. Yeah, 147. All right, so that ends tonight. All right, guys, that's about it. Have a good Thanksgiving, and we'll catch you guys in 2 weeks. All right, cheers. Thanks, everyone.